do shock first. Okay, so guys, starting today, we are doing the kind of change in schedule. I'm gonna try to get that sent out to y'all today before I leave. But we're only gonna be lecturing on shock and airway management today. All right, so we should have some extra playtime. You guys can get some hands-on skills. Everybody in Zoom, if you want to, like last time, I can leave the computer or the camera on and you guys can watch as we do the skills. But we're gonna do shock first. Anybody have any questions, comments, concerns before we get started? No? Okay. Was it a good test? I haven't gotten to look at everyone's grade yet, so I don't know if that's sarcasm or not.
Is it true that it appeared to me that the quizzes were more based on we have more book type stuff, where the tests seem to have more content from class section and stuff? Maybe not so much.
I don't make the questions.
Yeah.
I choose from a question bank, but I choose the questions for the test. Yeah, so possibly, but I don't like make the questions. I just pick which ones I like the best. All right, so shock. Guys, we've talked about a little bit in class already what shock is, right? When can you start to determine if your patient could possibly be in shock during your patient assessment? Okay, so specifically when we assess that CCT, right? What do I want to hear or see or feel in my patient? Warm, pink, and dry. That tells me that I'm adequately what? Perfusing. All right, guys, let's go make sure everyone's crystal clear on the definition of perfusion. What is perfusion? Okay, say that again.
That blood flow through the whole body.
Okay, so we have adequate blood flow, right? Which means that we have adequate blood pressure. And also in that blood, we have adequate what? Oxygenation, right? Because we can have blood flowing all day long, but if we're not getting those O2 molecules onboarded to those red blood cells, then it's eventually, we're going to eventually die because we have to have that oxygen. So perfusion means that my heart, my cardiovascular system, and my respiratory system are working efficiently and effectively. They're working together to make sure I have enough circulation, all right? So blood flow and oxygenated blood getting to every aspect of my body. Okay, is everybody good with that definition? Hope so. All right, so shock is, we're going to define it with the medical world is going to be a state of hypo, which means low or not too little, okay, perfusion. So shock is going to be hypoperfusion, right? We are going to learn through this chapter that there are several different things that can cause shock. There's several different things that can cause that state of hypoperfusion to occur, and there's several different types of shock. So everyone's good with perfusion. Okay. All right, so guys, again, what's homeostasis? Let's talk about that real quick. We like to make sure that we have an appropriate amount of levels of all sorts of things in my body, fluids, acids, electrolytes, sugars, all of that stuff, okay? Guys, if you have a healthy body, if we have those levels get out of whack for a little bit, your body can kind of what we call compensate. And we'll talk about that in this chapter as well, but just the end goal for the body during these different stages of shock and trying to get back to normal is to make sure we keep that kind of level measurement of everything that is in our body, okay? All right. Everyone's good on perfusion. Everyone's good on the theory that, not the theory, but the fact that if your cells, your organs, your tissues don't get oxygen, they die, okay? All right, so again, guys, we're also worried about getting that oxygen delivered to all of our cells, but we also want to get what out? Carbon dioxide, okay? So we want to make sure that that perfusion is occurring not only to oxygenate our body, but to make sure we're offloading that CO2. Because if we have too much CO2 in our body, we can become what? Hypercarbic, acidic, right? For one reason or another, and that's very detrimental to our system. It's a high acidity level. All right, so let's talk about our cardiovascular system, guys. There are three major components of your cardiovascular system when it comes to what can lead to shock. All right. So ultimately, at the end of the day, one of these three things, when it comes to the cardiovascular system, has a problem for us to go into that state of hypoperfusion. All right, we can either have a pump problem, a container problem, or we can have a content or a volume problem. So pump, container, and content. If I have a pump problem, what do you think is not working? Where is there an issue? The heart itself. All right, we will typically see a pump problem. Let's say if you've got like congestive heart failure, right? Left-sided or right-sided heart failure. Your heart is not pumping effectively. It's not pumping efficiently. It's not doing its job. That can lead to a state of hypoperfusion if it's not literally pumping the way it needs to. Okay, what about my container? What does that mean? So all of my vessels, right? All of the arteries and the veins that contain my blood that is getting pumped from my heart to the rest of my body. If I have a problem with those containers, those arteries and those vessels, that can lead also to a state of hypoperfusion. All right, what do you think the content problem is going to be?
What we're talking about, carbon dioxide.
Okay, so particularly blood. All right, so content or volume. Guys, not also just blood, but also what can lead to a state of hypoperfusion? The loss of what? Fluids, right? So any blood or fluids, a significant loss in that content can lead to a state of hypoperfusion as well. Okay, pump, container, content.
So is the problem with the vessels that they're not expanding or contracting as they should, or what's the problem?
For the most part, we're specifically going to talk about the containers when we talk about anaphylaxis and sepsis. But yeah. Oh man, here it is again. You ready to review blood flow of the heart? Okay, what are my two main dumping tubes? Superior and inferior vena cava. All right, they dump into what? Right atrium. We're going to go through what valve? Tricuspid. Try before you do something else. Yeah. All right, so we're going through the tricuspid valve into the right ventricle. All right, I'm going to go through the what valve? Pulmonic valve into the pulmonary arteries. All right, from the pulmonary arteries, where am I going? Into the lungs. Huh? Okay, but how do I get down to the alveoli? I'm in the pulmonary arteries. I'm now in the pulmonary arterioles, and now I'm in the capillary beds. And then I'm going to return back to the heart through the pulmonary venules, right? I got to get those teeny tiny ones to get out of those capillary beds. And then the pulmonary veins. All right, then I'm going to dump where?
Right atrium.
Left atrium. I'm going to go through the bicuspid or the mitral valve into the left ventricle through the aortic valve to the, all right, out to my systemic arteries. All right, I'm going to go to my systemic arterioles, my systemic capillaries, my systemic venules, systemic veins, and back to the, that was not bad for the select few who were vocal. All right, guys, this is going to come back into play. It's never going to go away. All right, this is part of one of the reasons we can go into shock. All right, when we talk about cardiovascular emergencies, we got to know this because we got to know normals so we can identify abnormal. All right, so again, guys, make sure that you're understanding that you've got to know this. It's not just a cram and dump for a test, okay? Okay, talked about that. All right, guys, is there any confusion? I know I talked y'all through getting a blood pressure and what it means and all of that stuff during the human body and then also when we practice vital signs. Is there any confusion on what you're actually hearing, how you're hearing it, what the systolic represents and what the diastolic represents? Is everyone pretty clear on blood pressure?
The systolic is like where they're counting the pressure of the blood. When it releases.
Yeah, so when we're releasing that dial to the left and we're kind of opening up that artery again, that systolic is going to be the true measurement of how forceful that left ventricle is having to pump out that blood to make sure it's circulating to the rest of my body. So it's going to be the higher number, the biggest force, the biggest amount of force.
Systolic is like where it goes.
Yeah, so that's going to be the last thump you hear, the lower number. That's going to represent the pressure of the blood once it overcomes all of that systemic vascular resistance, that kind of at rest moment, okay? Very good with that, because we're going to be talking about blood pressure a lot with shock. Okay. Yeah. All right, let's talk about pulse pressure. What is pulse pressure? Okay. So let's say we have a textbook perfect blood pressure of 120/80. Okay. 120/80. How do you get your pulse pressure?
Systolic, what is diastolic?
You take your systolic and you subtract your diastolic. All right, to get your pulse pressure, you will take your systolic and subtract your diastolic number. So for this particular blood pressure, my pulse pressure is, hello? 40. Okay. Guys, it's important. Yes, we've got to get an accurate reading of our blood pressure, systolic and diastolic, right? But this pulse pressure, because our overall blood pressure will tell us a lot about what's going on with the patient, whether it's way too high, whether it's way too low. But our pulse pressure is going to give us a very different, an additional indicator as to what could be going on with our patient. Okay. We want to see a pulse pressure anywhere from like 30 to 80-ish. It's considered normal. Okay. Once we start seeing a pulse pressure become 25 or less, not good. Okay, what is that telling me? If I have a lowered pulse pressure, what's not happening between the systolic and the diastolic?
There's not a very big pressure wave when the heart contracts.
So there's not a very big pressure wave, right? But am I having the correct amount of ratio of force and rest if I have a very low pulse pressure? No. Okay, guys, we have to have that state of relaxation to allow those chambers to refill, to allow everything to kind of reset so I can pump that back out, right? So if I have a really low pulse pressure, that's going to tell me I'm not adequately perfusing. We have a mismatch in that supply demand, if you will. That ratio is not where it needs to be. The heart's not going to be pumping effectively if I have a low pulse pressure. That's going to be indicative of shock, hypoperfusion. Okay? So we will talk about, right now I just want you to know that less than 25, that really low pulse pressure number is going to indicate shock. There's no way, if we don't have that right ratio of 25 or higher, we're going to adequately be perfusing in an adult, right? Because we're talking about all of this for adult patients.
What's the lowest like they're told for everything?
That what?
Can it ever get to a point where they match each other?
Not to where they match each other, but there is a condition or there's an injury that we're going to talk about that will present one of the cardinal signs of it is a very narrowed pulse pressure.
Which makes sense because you're not moving it.
So we'll talk about that. And so on the other side of that coin, guys, a narrowed pulse pressure can indicate a significant injury, and a widened pulse pressure can indicate another significant injury. So we'll get to that a little later, but right now I just want you to know if that number is low, that pulse pressure number is low, we're not perfusing, we're in shock. Okay. Okay. All right, so guys, just like we have a muscular component to those arteries, the capillary beds are the same way. Okay, because remember, when we sense any type of threat or any type of danger, okay, what kicks in?
Sympathetic nervous system.
Fight or flight.
Okay, so that sympathetic nervous system tells my who glands to release what hormone? My adrenal glands to release adrenaline or epinephrine. Okay, that hormone triggers that muscular component in my arteries to do what? Constrict, vasoconstrict. So my blood pressure can do what?
It goes up.
Remember the thumb on the garden hose analogy, right? If we're constricting, if we're making that diameter smaller, the pressure is going to be higher. Okay, so same with the capillary beds, guys. We already kind of talked about this. If your patient is really, really cold, right, we might not get a good pulse ox reading because all of the sphincters in the vessels are saying, hey, I need to preserve my body temperature. I'm going to what blood away from extremities and push it to my vital organs? Shunt.
Shunt.
So all of that kind of works hand in hand in the same capacity. It's to preserve those vital organs. That is going to be the end all be all priority of the brain, is to make sure brain, heart, and lungs are perfused. They've got what they need to survive, because we will die without the function of those organs. So again, guys, we talked about when it comes to the cardiovascular side, we can have three major problems, right? Pump, container, and content. But to have perfusion, right, we have to have my heart and my cardiovascular system working hand in hand with my respiratory system, right? My heart can be totally fine, super healthy, pumping, chugging all along just fine. But if there is no oxygen in that blood that my heart is pumping out, it's not going to matter. Everything's eventually going to fail if I don't also have a functioning respiratory system. Does that make sense to everybody? You can't have one without the other. You can, maybe for a very small window, right? My heart can pump and pump and pump, but if that blood it's pumping doesn't have any oxygen, we're not perfusing, those cells die, my heart's eventually going to die. Okay. All right, so we've talked about oxygen a lot. Yes, have to have that for these cells and these organs and these tissues to live. But what is also super, super important to make sure is getting to these cells so they can function and do their job? Glucose. Guys, that's the cell, that's gas for the glucose. That's our fuel. Okay. We've got to have glucose as well for my body to function, to do its job. And we've already talked about the CO2. We have to get O2 onboarded, but we also have to get that CO2 offloaded so we don't become acidic. The body does not like a higher acidity level. Okay, so proper O2 onboarding, proper CO2 offloading, and proper distribution of sugar all got to go hand in hand. Okay. Guys, what are my two alarm systems that help, at least my respiratory system, acknowledge we might have a deficit in one of these levels, and they sound the alarm to try to fix those levels so we can have adequate perfusion?
CSF.
Okay, so the filters in the CSF, that's what we're looking at the pH in the blood in the CSF, right? But what are my two alarm systems that kick in?
Aren't they the hypercarbic drive and then the hypoxic drive?
Remember my hypercarbic drive. My brain's gonna recognize that through that CSF and that blood, the pH is off. The number of the pH is too low. There's too much acid in my system. It's gonna say, hey, this is not conducive to homeostasis. I don't like it. This is not conducive to perfusion. So it's gonna tell my respiratory system to do what? Increase my respiratory rate and increase my depth. Guys, the faster and the deeper we breathe, the more what we blow off? Carbon dioxide. Okay, what's my backup alarm system? It's a hypoxic drive. It's not as sensitive, but again, guys, we've got to have a normal level of oxygen to maintain homeostasis. If that hypoxic drive is saying, hey, hypercarbic drive, I don't know if you're asleep up there, you hadn't had your coffee, whatever. Yes, there's too much pH, or there's too much acid in the system, but now we're to the point where there's not enough oxygen, right? So that hypoxic drive is going to do what to my respiratory system? Increase rate and depth. Okay, guys, we have the same goal, like it does the same thing, but we have two different sensors that kick in to increase that movement of air to try to stabilize that O2 and CO2 levels. Okay.
I'm sorry, after being an engineer for so long, I'm just continually amazed that this control system, you put these kind of control systems in plant, right? You have a fundamental control system to carry it, and then you have a backup to tune it.
Mm-hmm.
System.
I mean, I've been in healthcare a long time, and I'm still mind blown by
It's
it.
just crazy.
It's crazy.
Body just does it. It just does it.
All right, guys, so when we have that sympathetic nervous system kick in, we talked about those muscular components of the vessels. They constrict, increase our blood pressure, okay? What also happens with that adrenaline? What else increases? Heart rate, right? So again, guys, it's the brain's understanding that if I make my heart beat faster and if I make the pressure higher, there's more likelihood that I can perfuse whatever's not being perfused. It's trying to fix that hypoperfusion, okay? Through that increased what? Cardiac output. So the increase in the blood pressure, well, I guess the vasoconstriction and the increase in the heart rate is the brain's way to try to increase overall cardiac output. Okay. More blood, more pressure. I can try to hopefully get to all those cells and perfuse everything that needs this oxygen, this glucose, this CO2 removal. As it makes the heart beat faster, but it also makes the heart beat more forcefully. Okay. Okay, is everybody good with that recap of what perfusion is? What has to be in place to allow perfusion? What the goal of perfusion is? Speak now or forever hold your peace. Okay, everybody good in Zoom? Sweet, all right, moving on. All right, guys, so again, here are three main problems, right? Pump problem, container problem, and content problem. So we start to see this pump problem if we have a heart attack, right? Because what's happening when we have a heart attack? We talked about this a little bit in our pharmacology. Okay, but
It's not getting.
what's the end result of that plaque buildup?
Not getting enough oxygen.
Right. Particular part of the heart, or maybe the whole thing, just depending on what artery is occluded, is not getting oxygen. Okay. We just talked about it. Can any cell, any organ survive without oxygen? No. Guys, once we lose the function of that cardiac cell, that cardiac tissue, it doesn't come back. It doesn't work anymore. It just sits there like a bump on a log, and it makes the rest of the heart have to work harder to compensate for that dead tissue, that scar tissue just sitting there, not contributing to any type of conductivity, not contributing to any type of contraction.
Is that an immediate thing, or is that's it, it's done, never recovered?
What?
Heart recovery from damage of a heart attack?
It depends on the significance of the occlusion. Like if you got a heart attack from 100% occluded artery, yeah, it's going to be pretty immediate. But if you've got, let's say like it's a 50% occluded artery, then we can kind of buy some time with the treatment until we get you to the cath lab to get the
And
clot
so your
removed.
heart damage will be less significant and maybe even restorative long term, or no?
Possibly, yes. If we have that time window, if we're given that aspirin, that nitro, that O2, all of that stuff.
I asked one, my dad had a heart attack a number of years ago, and we were asking him about this stuff, and he said that his doctor had said after he went back for like a year physical, that his performance, his heart performance had actually improved because he really got on his exercise and changed his diet. And,
So if any part of his cardiac cells died,
yeah,
that hasn't been improved. That's gone, that's lost forever. But guys, the heart is a muscle, all right? You go to the gym to do what to your muscles? Condition them, get them in shape, make them stronger, make them better, right? So through that exercise, you can condition your heart to be healthier. So maybe the rest of his heart performance is
that makes
better.
more sense.
But yeah, you're not gonna get that tissue back if it's totally deprived of oxygen. All right, so if we have any type of trauma to the heart, again, guys, if we've got any type of injury and for whatever reason, that heart is not getting any oxygen, it's going to die and it's just gonna sit there and it's not gonna contribute to anything. The heart's gonna fail eventually. All right, so container problem, we're really gonna talk about sepsis. Drugs can cause this, particularly anaphylaxis. That's a big one. We're gonna kind of start talking about that today, anaphylaxis. And then a content or a fluid problem. All right, we talked about it, guys. There's two major things, blood and fluid, right? Because it doesn't always have to be blood loss that causes somebody to go into a state of hypoperfusion. Secondary to what? Because what do we call significant fluid loss? Hypovolemia. Okay. Huh? All right, so you can have something called hypovolemic shock. So that's going to be a content, a volume problem where you're losing too much fluid. And because that fluid's not there, what's going to start to tank?
Blood pressure.
Blood pressure. If you don't have an adequate amount of blood pressure, can you have adequate perfusion? No. All right, so hypovolemia or hypovolemic shock, can you be very familiar with that term? It can be caused by blood loss, either external or internal, but it can also be caused by just straight up fluid loss, right? Guys, you can die of dehydration. Doesn't mean that you're bleeding out, doesn't mean that your blood's being removed from your body, but all of those excess fluids that we need for homeostasis can be depleted. And if they're gone, you can die of hypovolemic shock secondary to dehydration. Okay, it's not just blood. Okay, we're gonna go over all of these today, don't worry. But be familiar, because guys, there's different types of categories of shock, and then there's different subcategories that are an example of those different types of shock. Okay? I know. I'm just as excited about it as you are. All right, so about cardiogenic shock. Guys, this is probably the most easiest type of shock to grasp. All right, what do you think cardiogenic shock means?
Shock that orients from the heart.
I have a cardiac etiology. Something is going on with the heart itself that is causing inadequate perfusion, that is causing hypoperfusion. Yep, that's a really big one. Okay. So, a big one with here, like Toddy just said, is heart failure. Guys, you need to start getting real familiar with the term CHF. What is that? It's part of your homework.
Congestive heart failure.
Congestive heart failure. All right, we'll talk about this next week during cardio. No, we won't, because we're just doing CPR next week, right? So we'll talk about it week after next when we talk about cardiovascular emergencies. All right, but congestive heart failure can be secondary to a heart attack. You can develop it once you have a heart attack. All right, or it can be from significantly uncontrolled hypertension. All right, so we're going to jump a little bit back into that blood flow of the heart. Okay. What is true globally, a global statement about the blood flow of the heart? It always has to go what way?
One direction.
One direction, not the horrible boy band, right? It has to flow in the same direction every single time, or we start to see problems. It's designed for that one-way blood flow. That's why we have those valves, those one-way valves, to prevent that backflow of the blood from going somewhere it shouldn't, the opposite direction. Okay, guys, this is, you gotta know normal before you know abnormal, right? Let's say particularly left-sided heart failure, because you can have left-sided and you can have right-sided. Okay, left-sided heart failure. Let's say there's somebody who has had just uncontrolled high blood pressure for a very, very, very long period of time. Okay, guys, what is happening to your heart if you have that high blood pressure on a daily basis? If you're not taking your medications, if you're not changing your diet, if you're not trying to get healthy with exercise, what's the heart doing?
It's pumping harder.
Hold on.
Yeah, I was about to say someone else needs to come in.
All right, your heart is doing what, Melody?
It's pumping harder.
Pumping hard day in and day out to overcome all of that systemic vascular resistance, right? You're not taking your meds. You're still eating really crappy food. You're not exercising. You're not trying to clean out all that gunk in your system. So that heart is working overtime every single time it contracts. Especially who is working overtime? The left ventricle. All right, guys, it can only do that for so long, right? It can only pump, overexert itself for every contraction, every minute of the day until it says, dude, I'm tapping out. I'm done. I'm tired. I can't do this anymore. Okay. So that's when we start to see that left-sided heart failure. It's done. It's not going to contract efficiently. It's not going to actually, like, those valves are not going to close all the way. Okay. So we start to see, instead of that blood being forced out to the rest of the body from that left ventricle, it starts to go back to where it came from. Where does the blood supply that goes to your left ventricle come from?
Lungs, I think.
Your lungs. If your left ventricle is not pumping effectively to get the blood out to the body, it's going to start to back up, and all of that blood and that fluid is going to start to overflow into the lungs. All right, so a significant side effect from left-sided heart failure is going to be what we call pulmonary edema. We're going to have significant fluid in the lungs. Guys, do we want fluid in our lungs? No. Why?
It's only meant to do oxygen and CO2 exchange.
Yeah, guys, those capillary membranes in the alveoli where we have that gas exchange, they're very permeable. It's super easy for those molecules to pass in and out of those capillary walls. But if you put that fluid that's backing up from that left side of the heart into those alveoli, they're going to totally block those capillary membranes. What's not going to happen? Gas exchange. Okay. So this is kind of a good, that the CHF, especially the left-sided heart failure, is a good combo between, we got a pump problem, significantly got a pump problem, right? My left ventricle is not pumping. But now we're seeing the side effects of, I can't have that gas exchange. Now my respiratory system's involved. That's a really bad combo for perfusion. It's not going to happen. Okay. Guys, that's as far as we're going to go into left-sided heart failure right now. We're going to get deeper into it, cardiovascular. But do you see how this pump problem leads to hypoperfusion? We have that fluid backup. We can't have gas exchange. On top of not having that O2 onloaded or onboarded to the blood, that left ventricle is not pumping it hardly at all out to the rest of the body. Okay, you need to be very familiar with that term, pulmonary edema. We're going to talk a lot about that. You're going to see a lot of that out in the field. All right, everybody good with that? Congestive heart failure, pulmonary edema, not good for perfusion.
So what is congestive heart failure actually mean?
Just that it's not going to go away. Typically, once you get left-sided heart failure, it's going to turn into right-sided heart failure eventually. Not usually, no. That's if you've got something wrong with like your SA node. Yeah. Yeah, because is congestive heart failure why they would put a pacemaker in? Not typically, no. Yeah, because the pacemaker is electrical. I mean, you could maybe get on the heart transplant list, but yeah, they're not going to be able to like surgically fix that left ventricle because it's just tapped out.
Interesting. So that's why you have these executives that are so sprung up. They haven't had a heart attack, but they have severe hypertension.
Oh, yes. Drop dead. Hmm? Jay, do you have a question?
No.
All right. Here we go with that. Yes, sir.
You said it blocks the membrane and alveoli.
Fluid gets down into the alveoli. It literally sits and it pulls up in the alveoli, blocks the capillary membranes, no gas exchange. All right, obstructive shock. I guess let's look at this word a little bit. Okay, what do you think obstructive shock means?
Something somewhere that's blocking blood flow.
All right, there's a roadblock somewhere that is causing the normal function for whatever. Maybe it's the lungs, maybe it's the heart, maybe it's whatever. It's causing a detour of that blood flow or of the function of that organ or system that's going to lead to a state of hypoperfusion. Okay. The three big hitters we're going to talk about right here is a cardiac tamponade, a tension pneumothorax, and a pulmonary embolism. All right, so cardiac tamponade. What is this? When you were going through your assessment, you were looking for something, you were asking if something was present that would be an indication that a cardiac tamponade is happening.
If the heart sounds are muffled or clear.
Okay, so you have two things actually. Yeah, you're listening for muffled heart tones, and also something else would present if we had a cardiac tamponade. Jugular vein distension. I guess 9 out of 10 times this cardiac tamponade is going to come from a trauma injury, a chest injury. Typically, it's going to be a blunt trauma directly to the chest, right in the area that your heart is. Okay, so the heart, I'm about to be blessed with my amazing artistic ability. The heart, not anatomically correct, is surrounded, it's encapsulated by a little sac called anybody?
The pericardial sac?
The pericardial sac. Okay, it's almost like it's just a thick kind of membrane sac that surrounds the heart and keeps what up against the heart? A little bit of fluid. Right, because guys, what is the heart doing day in and day out? It's pumping, so it's moving, right? It's constantly moving. So that pericardial sac keeps a little bit of fluid, the right amount of fluid for the heart to do its job and to not create too much friction, and just be nice and smooth. So there's a teeny tiny little bit amount of fluid in this pericardial sac that surrounds the heart. We like it to be there. It's good. Okay. Now, when we have a pericardial tamponade or a cardiac tamponade, what do you think is happening? If I have direct blow to my chest, okay, what can happen to that pericardial sac? It can rupture. It can get torn. Okay. So what can happen if it's ruptured? What can kind of flow into? Excessive fluid. Okay. Or guys, the pericardial sac could remain intact and the heart has an injury that causes one of the vessels to the heart to start bleeding out. So either way, okay, this pericardial sac is now having way too much fluid in it, way too much blood accumulating inside that pericardial sac. Okay, so what's going to start to happen if all of this pressure is building inside the pericardial sac, particularly if that pericardial sac is not ruptured? Where's all that blood going to go? It's going to stay inside that pericardial sac and it's going to build and build and build and build and build. All right. What do you think is going to start happening to the heart? It's going to be squeezed from all of the pressure of that accumulated blood inside that pericardial sac. The heart is going to start becoming under pressure. Right? Normally, when the heart contracts, it has enough room to do it nice and strongly. And then when it rests, to allow all of those chambers to what with blood, refill with blood, it has enough room to do that. What happens if you start kind of compressing the space that the heart has to work with? What do you think is going to happen to that, the performance of the left ventricle? Is it going to be able to pump as hard?
No, it becomes compressed.
Okay, so the heart, guys, it doesn't work well under pressure. Okay, so it's not going to have enough room to effectively contract. But then also, if it's consistently squished, it's not going to have enough room to do what? Relax and refill. So not only are we having a crappy contraction from that left ventricle, we're not having the appropriate amount of blood refill all those chambers. And eventually that left ventricle is going to have nothing left to pump out. Right? So cardiac tamponade is not good for perfusion. I think it's in the trauma chapters where I've got videos of how they fix that. in the ER and then the OR. I think we're gonna watch it right now.
So just to be clear, this, so your heart's there, and the sacs around it,
Mhm.
so there's like a lining on the heart and a lining on the outside.
Mhm.
So it could break this way, the blood comes out, fills this, or it could break this way, the
Uh-huh.
fluid from your body coming in.
We usually see it be most detrimental if the sac remains intact
Yeah.
because it just has nowhere for that pressure to go. There's no escape.
I mean, ultimately, it'd be like the heart just would go, right?
Right.
You know,
The heart's literally going to be compressed to the point where it cannot pump, and then that will kill you.
Can you fix that in the field, or is that a?
Hell
Pray to
no.
God, they get to the hospital.
No, I am not gonna crack a chest in the field.
Or rather, not fix, but
Yeah, so
Address.
the way that they treat it is called a pericardial centesis. It's really, really cool. I've got a couple of really cool videos that we're gonna watch. They can either rush them to the OR and crack their chest that way in an OR, and they perforate the pericardial sac, and you can see all the blood coming out. Or if it's in the ER, don't have time to go to the OR, they can like crack a chest this way. It looks like medieval. They literally like cut, saw, and like crack, and they can do it in the ER, but not within my scope. I would not want to do that.
So you'd hear the muffled noise. Hear that.
So, kind of sidestep into cardiovascular emergencies, guys. There is a triad. If we have a cardiac tamponade presence, it's called Beck's triad. You're gonna see, or you're gonna hear those muffled heart tones. You're gonna see that positive JVD. What do you think is the other one? Let's do some critical thinking here. There's a number involved in this. Just think about what's happening to the performance of the heart and how that's going to reflect in your blood pressure.
I think it's systolic blood pressure would go down.
Okay, how? Is your systolic going to go up or down?
down.
Your systolic's going to go down, right? Because it's not able to pump out effectively. So it's going to get weaker and weaker. So that systolic number is going to come down. What's happening to that diastolic? The effort, the energy that heart is having to work against to rest and refill is increased, right? It doesn't have that chill time or that chill environment to rest and refill. So that diastolic number is going to do what?
The
So we've
pulse
got
pressure.
a decreasing systolic and an increasing diastolic.
Yeah, that's a bad time.
That's not good. Not a good combo, right? That's called something very specific. We just kind of talked about this at the beginning of this chapter. Pulse pressure. So what do you think it's going to be? Is it going to be a low number for pulse pressure? Yeah. But the particular presentation that happens with this cardiac tamponade, with them coming closer to each other, is called a narrow pulse pressure. That's your third trifecta for cardiac tamponade. You got muffled heart tones, positive JVD, and a narrowed pulse pressure. If you have those things present, we got a cardiac tamponade. We'll talk more about that in trauma. We'll talk more about that in cardiovascular, but that's just how everything's gonna start tying together.
Can you re-explain, like where that extra food comes from, how it gets in?
So typically, we see it most obvious and most detrimental if the heart itself is injured and maybe a vessel that supplies blood flow to the heart is compromised. And so we're having blood leaking from there and it fills up the pericardial sac, it has nowhere to go, and it starts to compress. Muffled heart tones, positive JVD, and a narrowed pulse pressure. So guys, if those three things are in place, we're gonna have Beck's triad. BECK, the guy that discovered it. Put it all together. Okay. Bad day. Nothing y'all can do about a cardiac tamponade. There's nothing I can do about a cardiac tamponade except what? Except recognize that it's happening, know that it's bad, and have a significant sense of urgency when transporting your patient and including that information in your what?
Radio report.
Your radio report. Dude, get the trauma team ready, trauma activation. We got a cardiac tamponade. Because guys, there are some cases where you can say, hey, patient's critical, we've got this going on, you might want to consider bypassing the ER and going straight to the OR. They do that sometimes. Okay, so again, if you're not recognizing that there's a cardiac tamponade present, you're going to kill your patient.
Okay, and just so I can make sure that I'm following along, because that was a lot. So basically, for the cardiac tamponade, we're looking at distension in the veins,
Positive JVD.
muffled heart sounds.
Yep.
And the narrowing of the pulse pressure, where the systolic and diastolic blood pressure start to merge. So we're looking at narrow pulse pressure.
Correct.
Okay, all right, cool.
Guys, we'll go back over that, but I'm just introducing to you right now.
Oh, are there any medications you can't give them?
Because what is their pressure going to be?
Yeah, it's not gonna go away.
What are pain meds going to do to my pressure typically? Lower it even more. Yeah.
No, it's like suck it up, buttercup, then we gotta get to the hospital.
I mean,
What about that?
how do you think it would affect?
It's really-
Right. So we're going to make the heart work even harder and pump even faster and exert more energy, and it's going to kill them quicker. Because do I have a container problem? Are my vessels affected? Guys, what is this? This is a pump problem, right? Given epi is not gonna, my vessels are fine. I'm not worried about vasoconstriction. They're gonna do their job fine, but my pump is not able to perform. Okay. All right, tension pneumothorax. So does that make sense how that falls under obstructive shock? Right? That obstruction is in the form of the accumulation of blood and that pressure. It's not allowing, it's that roadblock, not allowing the heart to do its job effectively. Yeah, does that make sense?
Yeah.
Okay. All right, a tension pneumothorax.
Is it fun?
These are fun. Okay, what is this? What is a pneumothorax? We've kind of talked about this already.
Air in the thorax, because there's a hole in the lungs or a hole in the chest cavity.
All right, so remember when we talked about respiratory in the human body, are just empty sacs of air. That's what our lungs are, right? They can only inflate and deflate because of that pleural lining that coats the outside of the lung and the inside of the chest cavity, right? Those pleural linings come together, form a suction cup connection, and so every time my chest wall moves, it brings my lung with it and allows it to expand and deflate. If for any reason, as there are several reasons we can obtain a pneumothorax, we'll talk about that in trauma. We're not going to talk about that right now. But if there is any reason that suction cup, that pleural lining becomes severed, it becomes disconnected. My chest wall is going to be moving, but my lung's not going to be doing a lot of what? Moving.
I'm not going to be inflating and deflating.
Right. I'm not going to be having chest movement or air movement through that particular lung. Guys, they can move a little bit, but it's significantly affected, the movement of the lungs. Okay.
So specifically, when we say chest cavity, you're saying that air is going into that pleural lining.
So the air is escaping. It's no longer going into the lungs.
Right.
It's now escaping out into that thoracic cavity.
Is it contained by that pleural lining then? Or
So typically we're going to see this when the lung is perforated, when there's a hole in the lung.
usually?
So the air that's supposed to be moving into the lung and into the lung only is now escaping into the chest cavity. Okay, guys, that in itself is a bad day.
Yep.
So that is just that concept of what we just talked about. That's just a pneumothorax. Any pneumothorax that is not alleviated or treated by a pleural decompression, a needle decompression, will eventually turn into a tension pneumothorax. What's happening here?
Kind of the same thing. Too much air eventually squeezes the heart.
Kind of the same thing. Right? Why? Why does my heart eventually get squeezed if my lungs the thing that's affected?
Your chest cavity's not getting bigger, so too much air goes in and everything else gets smushed down.
As your chest cavity is only so big, it can only hold so much extra air, right? Unless you've got a major massive hole in your chest, that air that's escaping from the lung is not escaping from your chest cavity, it's staying in there. And just like that blood in the pericardial sac, it's going to build and build and build and build because it has nowhere to go. All right, so what do you think is going to happen if we start to have all of this pressure building in our thoracic cavity? What are we going to start to see happen?
It's gonna start impacting your organs, your vital organs.
Okay, let's say my right lung is collapsed. I have a right-sided pneumo. All right, so that escaped air from my lungs is going to start to fill up this void space in my chest cavity first. But once all of this space is taken up by that extra air, it's going to start to creep over here and say, hey, let me utilize this real estate. Okay, because again, the chest cavity is not getting any bigger. There's no escape for this air. It's going to build and build and build. It's going to start to creep over to the unaffected side of your chest. Okay, what's in the middle of your thoracic cavity?
Heart.
Your heart. What else? Esophagus, yeah.
Your aorta and superior and inferior vena cava
Your
thing.
great vessels, your aorta, your superior and your inferior vena cava. Right? If I don't fix that pneumothorax, that tension's going to build and build and build and build and build. And what's going to start happening to my heart and my great vessels?
Gonna start to constrict the vessels.
So it's not constricting, but just the pressure from that escaping air is going to kink off. Especially what great vessels are very susceptible to pressure. They're not designed to work well under pressure. Veins. So especially that superior and that inferior vena cava, from all of the extra pressure, they're literally going to start compressing until the point where they are completely kinked off. Why is that bad?
Well, it's
Because
close.
the blood is not able to get through.
When it's not going anywhere else either.
If I don't have the ability to have the rest of the blood from my body dumped into my heart by my superior and inferior vena cava, my left ventricle is eventually not going to have any blood to pump out the other side. Is that good? No.
Nope.
And guys, eventually that pressure will start to compress the heart as well. So it's kind of like the same concept of a cardiac tamponade, but instead of blood, it's air. Not good. What might I see during your patient assessment, knowing what we know now, knowing what's happening, that can tell me I have not just a pneumothorax, but a tension pneumothorax present? Okay, yeah, they're definitely gonna be short of breath. But what's a physical sign that I can see when I do my assessment?
Uneven chest rise.
The trachea shift.
So any pneumothorax, I'm gonna have unilateral chest rise, right? Whichever lung has collapsed, it's not gonna be moving as much. But when I have a tension pneumothorax, remember that pressure's creeping onto the unaffected side? So that's when we start to see that tracheal deviation, right? The pressure is actually getting so intense that it is starting to push over the airway anatomy. We will see the trachea deviated to one side. If you see tracheal deviation, we are very, very, very far along into having a tension pneumothorax where we don't have a lot of time to work with. That's a very late sign of a tension pneumo.
Is that like one of the first things that you said?
If we see a patient that has unilateral chest rise, difficulty breathing, then yeah, I'm going to take a quick glance at that trachea and be like, hey, where are we at with this pneumothorax? How much time?
So the pneumothorax is just like the affected area, and then tension pneumothorax is going to be still unaffected.
So we're only talking about this obstructive shock in the form of a tension pneumothorax. And the air from that original pneumothorax accumulates and starts to travel and compress the heart and great vessels. All right? So does that make sense why that falls under obstructive shock? All of that air is obstructing the performance of the heart. Okay? Everybody so far? Pulmonary embolism. This is another big one. Okay, pulmonary, was this regarding what? Who? The lungs. Embolism. What is this? Clot. A floater, we like to call them. Okay. So guys, how does a pulmonary embolism happen? What's happening in the body? Does anybody know? So, yes, that's part of it. That's the start of it. Somewhere in a patient's body, we have a clot, okay? Blood clot, typically. That can be for several different reasons. The patient has that blood clot accumulating or just kind of sitting in their vascular system somewhere, okay? So, if for whatever reason that blood clot, maybe it's sitting in a vessel in their legs. If that blood clot breaks off and it breaks free, where's that blood clot gonna go? It's gonna hop on that cardiovascular carousel, right? It's gonna be pushed through the vessels because the blood's forcing the movement and the motion of that clot. Do we like floaters in our circulatory system? Do we like clots? Do we like accumulation of blood? Do we like accumulation of air? Anything that's not supposed to be there. No, guys, not good.
No.
All right, so anywhere that clot lands and gets stuck, so let's say the clot is this big, just for example, okay? And it's traveling through the vascular system. Guys, does our vascular system have like a funnel aspect to it? It gets bigger and smaller, right? It changes shape, size. So once that clot gets to an area of the cardiovascular system that it can't fit through, it's too big to pass through that particular vessel, it gets stuck.
And jams up that vessel.
All right, if that blood clot is stuck in that vessel, do you think that blood flow is going to continue through that vessel where that blood clot has been lodged?
Maybe a little bit lucky, probably not.
Maybe a little bit if you're lucky, but usually not. So guys, in the instance where we have a blood clot that breaks off and travels through our pulmonary arteries, our pulmonary system, our pulmonary circuits, if it gets stuck there, that's what we're going to call a pulmonary embolism. Okay, you will see this referred to as a PE, not physical education in high school, right? A PE, capital P, capital E, is going to refer to a pulmonary embolism. You'll hear people say that. It's far less syllables. So we say, yeah, man, he's got a major PE. He threw a big PE. It's pulmonary embolism.
So when you have a blood clot, the doctor tells you not to fly because of the air pressure will cause it to travel faster.
Air pressure, and depends on the time of the flights. Like if it's a very long flight. But yes, I think we're gonna talk about pulmonary embolism in respiratory. So the next chapter we lecture on in this module, we'll talk about it, but yes, part of it. Okay, so if a clot gets lodged in my pulmonary vessels, my pulmonary artery, my pulmonary veins, what's not happening?
Not flowing through them.
Okay, it's not flowing through them, and if I'm not getting my blood from my lungs, it's not going where?
Left
The left ventricle.
The left,
the left.
the rest of the body.
Yeah.
Okay, because remember, we got to know that blood flow. We got to know that the pulmonary circuit, the pulmonary vessels directly supply the blood to the left side of the heart. So the left ventricle can pump it out to the rest of the body. And if that's blocked, that left ventricle is not getting any blood, neither is the rest of the body. It's got nothing to pump out. Okay, so this clot, this embolus, is obstructing the normal blood flow, which will lead to hypoperfusion, shock, and ultimately death if it is completely occluded and they don't catch it and they can't remove it. Okay,
How many patients do you have to deal with like that?
one of my horror stories deals with a PE patient. So I've had a couple, but one that I effed up on, and we're gonna talk about that in a second. But you guys, this happens. This is fairly common. Okay.
What are some like objective signs that we might look at this?
Difficulty breathing, for sure. Guys, with a PE, it's going to be a very sharp, sudden, ow, my chest hurts, and all of a sudden I cannot breathe, can't catch my breath. Hey guys, finding out and diagnosing, if you will, a PE has a lot more to do about your interview, your questions that you're asking the patient, than it does the signs. Because a lot of things can present with, oh, my chest doesn't feel good and I can't breathe. That can be a lot of things, but there are very distinctive, there's very distinctive information we can get from our patient during the interview that can say, yeah, this is probably a PE. We'll talk about those in respiratory.
Patients unresponsive, is there anything that you can objectively find this with, or patient has to be conscious and they will tell you about this? Wonderful.
Lovely. All right, everybody with me? We're good with perfusion, hypoperfusion, shock, all that jazz. We're good with obstructive shock. Is there anything that I've said so far that you're just like, I have no freaking clue what that means, how that means?
The symbolism, is it possible for that to occur in an artery with the pressure, or is it more likely to be seen in the vein, or is it always seen?
Can be either or.
Can be either.
Okay, okay.
Just for clarity, the pulmonary embolism, you said it's typically caught like somewhere else.
It usually starts somewhere else in the body, and then it works its way through the circulatory system. It gets to those pulmonary vessels, and that's where it gets too big to fit through, and that's where it gets stuck. Okay. Distributive shock. All right, what do you think is happening? What kind of problem do I have out of my three, my pump, container, and my content, when it comes to distributive shock? It's going to be a container problem. My vessels are not intact, or they can't do their job to distribute all of that blood to the rest of the body. So distributive shock is going to be immediately referring to a container problem, your vessels. Okay. All right, septic shock. Let's talk about this. What does this mean? An infection. Okay, it starts out with a localized infection. Whether that's you cut your hand on something, you didn't get it properly cleaned, you don't have like a tetanus shot, an update tetanus shot, something happens. Not really tetanus, that's a bad comparison. But you have a localized infection. If we don't get that infection taken care of, because guys, what is an infection? What is it?
Something that doesn't belong happily growing in your body.
Something that doesn't belong is happily growing in your body. Okay, yeah, so usually bacterial base, we can get those treated with antibiotics. We get rid of that ooey bacteria, we clean up that infection, it goes away. If we don't get that taken care of, what's going to happen to that infection?
Spread.
It's going to get bigger. It's going to get bigger.
It's your blood.
It's going to spread. And eventually, it's not going to be localized to that cut on your foot anymore. It's going to find its way into where? Your bloodstream. Really?
It's gonna be caused by a vessel leak.
It's great to give you morphine and stuff.
I mean, technically, I've had this too.
It was a dog right here that started creeping up. I was about to get on a flight to Rio de Janeiro.
No?
And I told them I couldn't, because I saw it.
It says just don't feel right.
No, I just saw the red creeping up the arm, and they told me to watch out for that.
Yeah. So is it good that if that said bacteria or those ooey gooey cooties from that localized infection get in the bloodstream?
No, because then they're everywhere.
No,
Because now that bacteria is going to be introduced to every aspect of my body. Because my circulatory system comes in contact with every aspect of my body, every cell, every tissue, every organ. Okay, so we move from a localized infection to sepsis when the bacteria from that infection gets in the bloodstream, and now it is global in my patient. I have several systems affected by this infection. Yeah, I forgot about that. I was septic about a month after my last son was born. Hospital stay, all that jazz.
Did you have a C-section?
Mastitis. So, not good. Lots of antibiotics, lots of fluid. Okay? So, why is this bad? If I get an infection and it goes to a septic level, if it's going all through my circulatory system, why is that bad? Toxins. Guys, that bacteria is not supposed to be there. It causes damage and death to these cells and these tissues and these organs. Okay? A side effect of that is these toxins, because it's in your bloodstream, the toxins are also in your bloodstream. And those toxins can degrade the composition of your vessel walls and start to make them a P word, permeable. Is that a good day if my arteries and my veins that are supposed to be a closed system to deliver all of this blood and perfuse the rest of my body now become leaky?
no, it puts you in a risk for hypovolemia.
Yeah, because what's going to happen to said fluid and said blood that's pumping through those now leaky vessels?
It's gonna be.
So we do get global vasodilation, yes. But what's happening to the fluid that's inside that vessel that used to be nice and strong and contained, but now it's got kind of like holes in it?
It leaks out. It doesn't go anywhere.
Yeah, that blood is getting off on this bus stop instead of going to its final destination at the organ or the tissue it's supposed to perfuse. Okay, so we start to see a state of hypovolemic shock because we're losing the blood and the fluids. It's no longer contained in my circulatory system. It's just kind of dispersing itself into the body, and it's not going where it needs to be. It's not doing what it needs to do. Okay. Everybody good on moving from a localized infection to sepsis and how sepsis can cause a container problem? Okay. All right, neurogenic shock, guys. This is again going to be the loss of the ability to have that vasoconstriction, right? This is typically going to be from a head injury, a spine injury. We'll talk about this a little bit more in trauma, but something in that central nervous system loses that ability to provide that vasoconstriction. We get massive vasodilation. And remember, if we have that garden hose and I cut a wider opening to that garden hose, what's gonna happen to the pressure coming out of that hose?
It's gonna shoot out.
No, if I have a water hose and I cut open a bigger diameter,
Oh,
make it bigger, the pressure's gonna decrease,
decrease.
right? If I have the garden hose and I put my thumb on it and I make the diameter smaller, that's when we start to see the increased pressure. But we lose that ability to vasoconstrict, to control and regulate the blood pressure. And we see that vasodilation, my blood pressure decreases. I can't adequately perfuse. So here's a little visual. There's my normal diameter, okay? And then there's the much wider dilated diameter when I have neurogenic shock in place. This is going to significantly decrease my blood pressure, decrease my cardiac output, decrease perfusion. It's going to lead to a state of shock, hypoperfusion. Everybody go with that? All right, anaphylaxis, because we're going to talk, we're the tip of the iceberg for anaphylaxis. Okay, because this is a major issue. You've got to be able to 100% accurately diagnose, because what is my treatment for anaphylaxis? EpiPen. You've got to make sure you're giving someone an EpiPen that they really need that epi. We're going to have to make sure we can differ between an allergic reaction and an anaphylactic reaction, because they're two major different, big, drastically different things.
I have a question I'm just remembering. So one of the contraindications, there's contraindications for epinephrine, but is it really?
No.
I mean, like, it's kind of.
Never. No. You give epi, if it is true anaphylaxis, you give epi first and you ask questions later. All right, so what's happening during anaphylaxis? Give me just a nutshell statement of anaphylaxis.
Catastrophic allergic response.
Violent reaction.
So a catastrophic reaction to a certain substance, right? I kind of talked about this. We have something exposed to our body at least bare minimum once. Maybe it's several times we're coming in contact with this substance. Maybe peanuts, okay? You eat peanuts throughout your life. It takes a little bit for your body to recognize, hey, whoa, I don't like you. All right, little peanut antigen, I don't like you. I'm gonna put a marker on you. So the next time I see you in my body, in this system, coming onto my turf, shit's gonna go down. Crap's gonna go down. All right, so instead of just being a little bit sensitive to that subject or that substance coming back into the body, the next time your body is exposed to peanuts, your body freaks the F out. It loses its mind, it overreacts, and it does everything possible to the most dramatic extent to try to get rid of that substance.
Why? It's like my little brother, he said, it's like all the time.
And now he's allergic.
Yeah, it happens. Immune cells will eventually die, or new ones can be generated, so you can lose allergies over time or get new ones.
That's why sometimes, guys, you run into these people who are eating at a seafood restaurant and they go into anaphylaxis and they're like, what the F, dude? I've been eating shrimp for 30 years and this has never happened. So yeah, it
You can
just,
spontaneously get new ones. Isn't that wonderful?
yay, nothing to be afraid of at all.
But old ones could go away, huh?
Or your body's reaction to them can become less sensitive.
I have a hard way whether it is or not.
Right. Let's hope you still have an EpiPen.
Well, I mean, when I was young, I had a severe shock. My mom's a retired ER nurse. I got bit by a bee. I was upstairs after mowing the yard, you know. My dad was downstairs. She came home. She was like, I'm going to the hospital. She screamed at my dad on the way out. And the next thing I knew, I was tied up by bees the whole 9 yards. So I carried that for 10 years.
Yeah.
But been stung by bees and wasps and stuff, since then, we've never had a problem.
So, yeah, okay, just.
Goes down crazy.
So
I
guys,
wondered if that was normal.
Yeah, that happens.
with anaphylaxis, okay, there's several different things that happen, but there's something specific that happens in the body that takes us to from an anaphylactic reaction to anaphylactic shock. Okay, what do you guys know about anaphylaxis? What's some common presentations? All right, your airway. It's a big one, right? We start to see bronchoconstriction, bronchospasms. We're going to hear wheezing. And guys, it eventually gets so bad where your trachea, your bronchi altogether will swell shut and your airway closes off. Okay. We start to get hives, like little splotchy red spots, typically on the core, on the neck, on the face. All right. We also see global vasodilation. And because of a specific hormone that is released, a massive dump of this hormone throughout your body during an anaphylactic reaction, that particular hormone, again, makes your vessels leaky. It makes them very permeable. So it's kind of the same end result as that septic shock we just talked about, but for a different reason. Okay, so we have massive vasodilation. We're making that hole wider, which is going to decrease pressure. And on top of that vasodilation, we have increased permeability to these vessels. So we're going to have all of those fluid in that blood, like we just talked about, leak out of the vessels. Is that conducive to perfusion?
Nope.
Your airway swells shut and your blood pressure drops, and that's what kills you in anaphylaxis. And how quickly does this happen?
Very fast.
Minutes. Okay. So like I said, we're going to jump way deeper into the A&P of anaphylaxis in a different chapter, but is it okay with you guys why anaphylaxis is a distributive shock? We get massive vasodilation and the vessels become leaky and permeable. We go into a state of hypovolemia. Okay. Guys, there's three main categories of allergens out there. Again, we'll jump into this more so in the other chapter, but typically you see allergic reactions or anaphylactic reactions to foods, drugs, and environmental stuff. So foods like shellfish is a really common one. Peanuts are a really common one. Drugs, a lot of antibiotics, like a penicillin allergy. It's pretty common. And then environmental, any type of dust, dander, bee stings, any type of venom, particularly from insects, is going to be that other big category. But this is just kind of extra information about anaphylaxis. But for now, on the terms of shock, everyone's good with that. Anaphylactic shock is distributive. We have vasodilation, and we have increased vessel permeability. That's all I want you to know right now.
I just have a quick question regarding the categories of exposure.
Yes.
When it comes to the ingestion part, right? One of the symptoms that it was saying that comes with anaphylactic shock is nausea and vomiting.
Can be, yeah.
Is it the same thing as, like, for example, like my mother, for example, she can't ingest pork, but it's not like it doesn't go into a state of her not being able to breathe and stuff like that. It's
so there's a difference between an allergy and an intolerance.
Okay, see, that's what I was trying to figure out, because I was like, she doesn't have, I didn't know if that was like considered like a mild case. So that's more considered an intolerance when the body automatically.
Yeah, intolerance is going to be if you eat that, like you hear lactose intolerance a lot. People can't have dairy products.
Right.
Or, whatever you said, pork. Your mom can't eat.
Oh yeah, she can't eat pork.
Yeah, so the body might just not like it in the system. Typically with an intolerance, you'll see maybe some nausea, vomiting, maybe like diarrhea, like a bloated stomach. So that's more of an intolerance. It doesn't freak out that it's in the system. It just doesn't deal well.
Intolerance is usually
With
you can't digest it
digesting.
correctly.
Oh, okay. Yeah, because I was just wondering, because I just happened to notice it was saying that it was like the abdominal cramping, the nausea, it can do vomiting. And I didn't know
Yeah,
if that
that
kind
kind
of
of
fell in
goes
that same
backwards.
category. Okay.
So again, a proper interview, good questions, getting as much information as we can. But yeah, that can fall under intolerance or allergy.
Okay. Thank you.
All right, psychogenic shock. What is this? Does anybody pass out at the sight of blood? If so, please reconsider your choice in enrolling in this course.
Side of blood.
All right, so this is, guys, this is going to be like an emotional incapacity to deal with something. Right? You see it all the time portrayed in movies or TV shows where, or, you know, maybe in real life. We had a student, he was in my class when the 8 EMTs were practicing the IVs, and he volunteered to get stuck like with a needle. Y'all, twice. He passed out in class.
He went back for a second one?
Oh yeah,
I mean,
he just turned pale white, and he was like, "No, I'm fine," and then just like fell over in the chair. And this was, I mean, just like your stature.
Why'd you let him do it?
Hard.
Because he volunteered. He's like, "No, I'm good, I got it." He didn't like fall down the second time, but I'm just like, Liam, just go home. Uh-huh.
persistent.
Sure. So yeah, something like that, that's maybe like visually traumatizing, or if you know, like dads passing out in the delivery room all the time, right? If somebody gets really, really bad news, like let's just say somebody just told them that a loved one has died or is seriously injured, okay? If that brain can't comprehend and can't process and can't deal with that stimulus, all right? Guys, the brain's way to reset and to refresh, have you tried turning it off and turning it back on again? Is passing out, having a syncopal episode, all right, fainting. So it does this by a sudden spasm, a sudden vasodilation, which causes an abrupt decrease in blood pressure. And the brain says, whoa, can't handle this. We need to reset and start from scratch. So because of that abrupt vasodilation, we have that syncopal episode. Everything gets reset to normal, that homeostasis. And then hopefully, ideally, your patient will wake up, come back to.
So does this usually happen when you like get to a scene and the other person is reacting to it?
Or we're called out because the person, our initial patient, had that initial reaction, passed out, and then they called 911, and usually by the time we get there, they're awake. But it could be either or. Okay? We'll go into this during neurological, the really big bad causes for syncopal episodes and the really minor causes for syncopal episodes. Okay. Guys, hypovolemic shock. This one's pretty straightforward. Okay. What are 2 things we can lose?
Blood and fluid.
Blood and fluid. Right? Give me an example of how we can lose blood to the point of hypovolemic shock. Bleeding. How?
Internal bleeding.
Internal or external. Right? If we have an open laceration or a GSW to the thigh, and I have nicked that femoral artery and I have that open wound, I'll be bleeding out. My circulatory system is not closed and contained anymore. There is a hole, and that blood's escaping from the hole. It can happen internally as well. All right. If I have my spleen is lacerated or is ruptured from trauma, okay, there's vascular supply to every single organ that we have, guys. So that vascular supply that's supposed to be going to that particular organ has been compromised. It's now an open system. I don't have an open skin wound to see it physically, right? But that blood's still leaking out of that vessel. It's not going where it should be. I'm depleting my supply of blood from my overall circulatory system. That's going to lead to a decrease in blood pressure, which leads to a decrease in perfusion. Okay? So guys, when we talk about fluids, what's fluids? How can I lose fluids to the point to send me into hypovolemic shock? Sweat. Okay, yeah, so if you've got somebody who maybe is stuck out in the wilderness or is like running a crazy marathon, we're sweating out fluid for thermoregulation. We're also with that too, guys, what do we lose during our sweat as well? Electrolytes. Electrolytes are part of homeostasis. That's why if you're gonna be sweating significantly, you do need to drink a Gatorade or a Powerade or something that replaces electrolytes and fluid, because your heart gets really pissed off if we have significant electrolyte imbalances. Right, but if you're not replacing that fluid that you're losing, yeah, hypovolemic shock. Burns. Guys, if you have a patient who has 3rd-degree burns to a significant amount of their body, that hypovolemic state, on top of probably later on infection, but that acute reason that these significant burn patients die is hypovolemic shock. Because what happens with a 3rd-degree burn? What's lost during a 3rd-degree burn?
Your pores, like your skin.
Everything. Guys,
Yeah.
your sensory nerves, your vascular supply, all of that plasma and fluid that is making up that cell, it's all gone, completely gone. Literally that fluid in a sense gets like evaporated from your body for a 3rd-degree burn. So if you have that to a massive area of your body, all of that plasma and that fluid, it's gone.
It's basically like your body is suffocating. Isn't it? Because I mean, it's because I mean, it's like as far as like a basic description, it's almost like your body is suffocating because you don't have access to your pores being able to like. I mean,
yeah, the loss of like your pores and that thermoregulation, that's not gonna kill you like the fluid loss will.
Oh, okay.
That's a long-term consideration I have. Like infection is going to be the main killer of significant burn patients if they can survive that fluid loss, right? Because we don't have anything to cover up. Our body, like every area that has a 3rd-degree burn, is completely, totally open to outside bacteria. There's nothing to cover it. So yeah.
Let me try with this skin grabbing on.
Because I would not, on the most, maybe on the most evil person in the world, on the planet, I would not wish a significant 3rd-degree burn to a big portion of somebody's body on anyone. Going through the burn unit for paramedic school, that messed me up. Those patients in there. That's when I had a conversation with my husband. I was like, if that ever happens, pull the plug. Like, I would not want to live. There's a lot involved. It's like for the rest of your life, you're having to have multiple skin grafts. You're having to like continuously like painfully stimulate that skin so it grows and it works like it's normally supposed to.
Isn't that what they like take this skin from your body to
Or somebody else's body. Or a dead body.
My mom says the same thing.
All right. So again, guys, that plasma, that fluid can lead to hypovolemic shock. Again, any massive loss of fluids, I don't care if it's blood or plasma or whatever, leads to a decreased blood pressure, which leads to decreased perfusion. Okay. Guys, on the same side, okay, vomiting and diarrhea, that's still fluid. Okay, excessive vomiting, diarrhea without being able to replace or replenish those fluids and electrolytes can kill you. All right. So it's not just blood when we talk about hypervolemic shock. Okay, so we kind of already covered this, right? We've got to have a fully functioning cardiovascular system, and we have to have a fully functioning respiratory system to make sure that they're conducively working together. Because I can pump blood all day long, but if that blood's not oxygenated, if I'm not being able to get rid of that CO2, right, it doesn't matter. Okay, I can be having beautiful gas exchange in my lungs, right? My lungs can be working fine, but if I have a significant pump problem or a container problem, and that gas that I'm having exchanged isn't getting distributed from that cardiovascular system to the rest of my body, it doesn't matter. All right, you've got to have both working hand in hand to have adequate perfusion at all times. We'll talk about carbon monoxide and respiratory. You want to take a little break? Okay. 10 minutes? Sure? All right, guys, going to take a little 10-minute break, then come back. Okay, guys, so it's really important too that you do understand we have certain stages of shock, right? Some are better than others. So we already talked about my body likes homeostasis, right? I like a certain amount of fluids. I like a certain amount of all sorts of things. And the body's going to do what it can physically to try to make sure that we keep at that homeostasis level. All right. So once we maybe start to lose a little bit of fluid, once we maybe start to have a little bit of pulmonary edema or a little bit of pressure from, say, a tension pneumo or cardiac tamponade, okay, that first initial state of shock we're going to go into is going to be called compensated shock. So what does this mean? But what does compensate mean? All right, so if the rest of your body is physically able to, okay, it's healthy enough to, let's say we're starting to lose a little bit of fluid somewhere. Let's say you got really, really bad food poisoning and you are just living in the bathroom all night. You can't keep anything down. You're profusely having diarrhea and you're profusely throwing up. We're starting to lose fluid, right? Have you guys ever been in a situation where you've been so dehydrated, you start to feel your vital signs kind of change? What starts to happen? Start to feel dizzy. You feel your heart rate increase, right? So if your blood pressure is going down, say secondary to dehydration, the rest of your body is going to try to pick up the slack and work harder to make sure that we're still trying to perfuse even with the lack of that fluid or in the absence of that fluid. Right? So if we start to have a little bit of dehydration, we're starting to lose some fluids, my heart rate will increase. Okay, I might not have enough fluid to pump out and have an adequate blood pressure that way. But if my heart pumps faster and harder, it's going to get more blood out and still try to perfuse, even though I don't have that fluid in my system. Okay, so the very early stages of shock, we're in compensated shock. If the rest of my body is physically able to, if it's healthy enough to, it'll try to pick up the slack. To work a little bit harder, go into overdrive to compensate, to make up for the lack of those fluids. That makes sense to everybody? Okay. So with compensated shock, you might see we start to maybe get a little bit of altered mental status, might be a little confused. We start to see again that pale, cool, clammy, right? When we assess TCT, I want to hear warm, pink, and dry. Guys, why is warm telling me I'm perfusing?
Blood warm.
Blood's warm. Okay? So if I have an adequate amount of blood being circulated to the core of my body, it's going to feel warm. Why do I want to hear or see pink?
Blood is red and the top of your skin.
Yeah, that's literally telling you that the blood is coursing through those arteries and those veins, and it's pushing up against your skin, and that's what gives you that pink appearance. Blood flow pushing up against the skin. Why do I want to hear dry? I'm sure. So this deals more so with the blood pressure itself. Guys, when we start to have that decrease in blood pressure, it's a stress response from the body. We start to perfuse. Okay. If we have like, I'm not talking about like dripping in sweat. That's a little bit different, right? But if we just have kind of like a little moist condensation on top of the skin, we call that kind of clammy. Or the fancy pants word that starts with a D. Does anybody know what it is? Diaphoretic. Your patient will present with diaphoresis, or they will be diaphoretic. Just that little bit of condensation. That's a stress response from the body because it recognizes, I don't have enough fluid. I can't properly perfuse. We need to fix this. We need to do something about it. This could be bad. All right, so pale, cool, clammy, not good. Indicative of hypoperfusion. We increase our respiratory rate. Okay, we might see some nausea, vomiting. We're gonna start to see a delayed CRT, especially in kiddos. We'll talk about that in a second. Guys, this is, we still have time to fix this. What do you think's gonna happen to my heart rate? It's going to go up in compensated shock because, again, it needs to beat faster and it needs to beat harder to make up for that lack of pressure. I'm going to see an increased respiratory rate. So, again, let's get as much O2 on board as we can. Let's blow off as much CO2 as we can so we can maintain that gas level homeostasis. Okay, with this compensated shock, we might start to see very minutely that blood pressure starting to dip a little bit. Right? It's below normal, but it's not in really, really, really bad territory yet. Okay. If we don't fix it here, because guys, what can AEMTs do? What can paramedics do right here in this compensated shock stage? Fluid resuscitation. Right? If you're in a state of shock because you're not perfusing adequately and your blood pressure is crap, when you go to A, and as a paramedic, we can give you fluids to replace what you've lost. Bring your blood pressure back up. Okay, we might not fix the exact root cause of this fluid loss or this hypoperfusion, but we can help bring that pressure up, at least temporarily. If we're not fixing not even the underlying problem, but the signs and symptoms, right? Especially that blood pressure in this compensated shock stage, we're eventually going to go to decompensated. Okay, guys, this is where we start to see that blood pressure drastically go down. Guys, your blood pressure is the very last vital sign to hold on to that little ounce of hope before it starts to decrease. Once we start to see that blood pressure tank, we're on a very, very, very slippery slope. Okay, your blood pressure is the last vital sign to drop off or to start to decline during the state of shock. So if you have a patient who has a systolic of like a 70, when you come on scene, we're in bad territory and we've been this bad for a little bit. Okay. So again, we start to see the blood pressure fall, the breathing starts to become a lot more labored. We start to see that cyanosis presentation. Is that moving? Or is it just me being super?
It's moving a little, it's shaking.
And then we start to see our pupils start to dilate. Guys, this is where we're actively crashing, okay, in this decompensated stage. This is harder to come back from because this is when we really start to see oxygen deprivation. And then guys, after we have this decompensated shock, there's a third stage that we go into. What do you think it is?
Catastrophic shock?
I mean, it's another adjective. Starts with an I. Irreversible shock. As your cardiac output at that point is so low, the function of your organs is so low that there has been permanent damage. Secondary to that lack of fluid, secondary to the lack of oxygen, secondary to the accumulation of that CO2. All right, so that irreversible shock, we're gonna have permanent damage, if not brain damage. This is typically where we see to the point where these patients are on like life support. They can't physically support their vital systems and functions on their own. We're just too far gone. Okay, so compensated, you're gonna start to see your vital signs, possibly your blood pressure a little bit increase. Why? Your body's trying to make up for whatever's lacking, but also what's your brain perceiving? This is a threat to your life, literally, right? So you are going to have adrenaline pumping through your bloodstream. That's why you might see a slight temporary increase of blood pressure because of that vasoconstriction from the epinephrine.
So why does anaphylactic shock, why is it dilate if your body perceives danger?
Because it's beyond the response of your natural adrenaline hormone. It's just like that dramatic, exaggerated response that causes a vasodilation. But that's why we give epi. That's a major dump of epi to cause the vasoconstriction and reverse it. Okay. So compensated, we'll see maybe a little increase, like minor increase in blood pressure, definitely increase in heart rate, definitely increase in respiratory rate. But when we start to go do that decompensated shock, everything starts to decline. Okay, we start to see bradycardia, we start to see bradycypnia, we start to see lowered blood pressure. We're definitely going to have altered mental status in this decompensated shock stage. Irreversible, typically unconscious, unresponsive. All right, guys. Right now, before we jump into the specific pediatric chapter, there is a major, major, major concept you've got to grasp about kids and adults and their stages of shock. Okay. Adults, we have more mature systems. We can handle things a little bit better. We have kind of an even, if you will, compensated and decompensated shock stage. Okay. We have a much longer than compared to kids decompensated shock. We decline a lot slower. It's easier to bring back an adult from that decompensated shock stage. When it comes to kids, they will compensate for a very long time. But once they hit that point where their body's like, hey, I can't do this anymore, their decompensated shock stage is almost non-existent. So they will hold on, and then fall off that cliff and crash extremely quickly. All right, whereas adults will compensate for a little bit, but we have a gradual decline from decompensated to irreversible. Kids don't, guys. It is very abrupt. All right, so if you come on scene and you're looking at this kid and they are sick, they're pale, they're not tracking you, they're lethargic, they're moving very slow, they're really working to breathe, what is the very first question that needs to come out of your mouth?
How long has that been going on?
How long have they been this bad? If your mom, the mom or caregiver says, oh, they've been this way for a few hours, bad, bad, bad day. Okay. But if they say, oh, they just started acting like this 10 minutes ago, we've got some time to work with. You've got to understand that kids will compensate until they hit that plateau and they go down extremely quickly. All right, so you need to gauge how much of what we call a pucker factor is playing into this call. All right, if your parent tells you, yeah, they've been like this for a few hours, you will kind of pucker your butt a little bit because you're like, oh shit, this is bad. That's a big pucker factor. All right, but if they're like, no, they just started getting this bad 5-10 minutes ago, I called you immediately. Okay, we can work with that. It's still going to be a code 1 call for sure, but you might not have to anticipate doing CPR on your pediatric patient if they started that bad 10 minutes ago versus a couple hours ago. Okay, so just make sure that you understand that global statement that kids compensate a lot longer, but then they crash. Whereas adults, we have just a gradual decline.
What's the time frame for a shock usually outside of like anaphylaxis or like a major traumatic injury like a femoral artery being cut?
It just depends on the age of the patient, the overall health of the patient. I mean, it can go anywhere from hours to days. It's just going to be case by case. All right, guys, again, we don't go through these every single chapter. Some of the things are changing. We'll talk about the things that are pertinent to what we're discussing in this chapter, but we're not going to go through every single one of these slides. Don't freak out, okay? When should you start picking up that your patient is in a stage of shock? When should that start to become apparent to you? During your general impression, really, right? If you walk up on scene and you see a patient who's either like, laying in a significantly altered, they're not really tracking you, we might see that they're already having that clammy appearance. If they're really working to breathe, right? If they don't have that pink color to them, that should be their first cue is, oh, okay, maybe we've got a sick patient here. Let's go ahead and get this stuff taken care of. Okay, so just make sure, again, you're getting a good picture of your patient when you walk on scene. So we can start having those, hey, we need to kind of raise the alarm here. We need to expedite this. This could be a really bad off patient, okay? Again, guys, we'll go into the specific questions that are going to really cue you in, especially on something like a pulmonary embolism type thing. But you're going to hear me say this over and over and over again. When it comes to your assessments, guys, every single patient, every single vital, every single question, every single time. Don't ever omit assessing a certain region or not getting a certain vital or not asking a certain question with any of your patients when it's pertinent or relevant, because you're going to miss something if you get tunnel vision, and that can lead to the death of your patient. Trust me, I know. That's why I'm a stickler about you don't omit any vital signs. You don't forget to ask any question. You don't forget to do any type of assessment on any patient, because you're gonna miss something, I guarantee it. Okay? What's shock treatment? What's shock management? Because we literally talked about this when we did the patient assessment. Okay, so high flow oxygen. Conserve body heat, put a blanket on them, crank up the heat in the back of the truck, and calm them. Okay, that's a good thing to do. But medically, guys, why am I giving high flow O2 to somebody who's in shock?
Poor perfusion.
Poor perfusion. I'm going to super saturate those red blood cells because I don't know how many of them are getting where, and I want to make sure, guaranteed, there's oxygen available for the body to distribute. Why am I doing body heat conservation?
Hypothermia is bad.
Hypothermia is bad. Guys, that's part of that homeostasis. Again, I want to keep who warm? Your vital organs, right? Okay, and then why am I having this third treatment for shock management that's going to help with my blood pressure? Nobody?
There's no safe fluids, right?
No.
Safe competition.
Potentially
Yeah.
elevate the
Place them in a supine position. If we can rule out a spinal cord injury, we can elevate their feet also. Guys, what is placing them supine gonna do? How's that gonna help me? How's it gonna help my patient?
Even about the blood pressure, it's not pumping up.
I'm not fighting against gravity to perfuse my vital organs. If my patient is sitting upright, all right, my heart is having to work harder to try to pump against gravity to make sure that my brain's being perfused. If they're in a state of shock, we don't have that luxury to expend that much energy. I'm gonna lay them supine. So now I'm flat, my heart doesn't have to work as hard to perfuse my vital organs. That can help with my blood pressure. It can take some of that work off of the heart if we're not fighting against gravity. Y'all were saying that shock management yesterday or the lab day when we were going over patient assessment, but now you know why we do it. High flow O2, body heat conservation, and place them supine to try to help get as much perfusion as we can, at least to the vital organs. Okay? Guys, are we going to fix any kind of cardiogenic shock? Are we surgeons? Can we physically fix the heart?
Yeah.
No. Supportive measures, guys, again, high flow O2, shock treatment, recognizing that there is a major problem is the best thing you can do for your patients. If your patient's presenting with Beck's triad and you're like, oh, your blood pressure is low, but I don't know why it's low. So yeah, let's take you to a non-trauma facility. Let's say they live in South Atlanta. They live off Cleveland Avenue, and their go-to hospital is AMC South. South Fulton, used to be South Fulton Hospital. Y'all might not know it now, guys. That's not a trauma center. That's a boo-boo, here, let me give you a Band-Aid ER. They can't really handle a lot of critical patients, like at all. So if you're not recognizing this as Beck's triad, you're not recognizing that it's secondary to a cardiac tamponade, you're not transporting them code 1 and you're not taking them to a trauma center, your patient's gonna die because of your lack of realization and lack of sense of urgency. Okay, so recognizing these major problems is the biggest thing, the best thing you can do for your patient, even though there might not be any interventions you can perform within your scope or within my scope, right? Talk about these later when we get to cardiovascular emergencies. I can fix I can fix a pneumothorax. Paramedic, ALS can fix a pneumothorax in the field. Again, recognize what it is, understand that you need ALS now. But then also, guys, when it comes to this, what's something you need to think about? What are some things you need to weigh? Time. Okay. Give me an example.
So far away, so.
Yeah, if you're closer to the hospital than the ALS team is to you, then you're better off taking them to that right hospital.
What if you're 3 blocks from Grady and ALS is 20 minutes away from you?
You can go.
Yeah, load them and drive real fast. It's going to take you a shorter amount of time to get that patient to the emergency room than it will to have ALS come to your scene. That's going to be something that you're going to have to make judgment calls about. Are you closer to ALS or are you closer to an emergency department? Okay.
How do you document that then? Like basically if you have that short amount of time, because we've gone over that legal and documentation stuff and you have to fill out like the patient care report and all that. And you've got, like you said, you get on scene, you realize there's a super serious problem and you're blocks away and you throw them in the back, do what you can, get them to the hospital. Like, is there a code for like, hey, we were done in like 3 minutes?
No, it'll reflect, because that's another thing you keep track of in your chart are your times. Usually the computer system will do it for you, but you have to document when you were dispatched to the call, when you arrived on scene, when you made patient contact, when you left the scene, when you arrived at the hospital. That's all going into your documentation. It's usually auto-populated by the computer system, but it would reflect in the documentation that you were 5 minutes away from the hospital, and it was a good judgment call.
And so in that case, you wouldn't have to do, it's acceptable in that case that you're going to basically be truncating some of the assessment options, basically, because you recognized a life threat, knew you were close, and then transported, just the different types of the assessments later on, basically.
Yeah, because sometimes you're not literally going to have time to do like a detailed, like, are you saying if you like omit an assessment or like miss an injury because you were focusing on this life threat?
Exactly.
Yeah, sometimes that's going to happen. Literally, if you're right down the street from Grady or a hospital and that patient needs to go right then and there, manage your ABCs and they can figure out the rest later. Life threats and ABCs, if you have that covered, that's what's going to kill your patient, right? So yeah, sometimes we don't get to assess our patient in their entirety. But that should be reflected in your documentation. If you have a 15-minute transport, right, and you're not documenting that you did any kind of assessment, that's a problem. If you have a 4-minute transport, that's different.
If you're in a more remote area, so not really relevant to Grady specifically, but if you're like far away, and you're far away from the hospital and far away from, but close-ish to ALS, would you try and meet them in the middle or just stay on?
You can do what's called like an ALS intercept. Yeah, you can get on the radio or on the phone with dispatch and say, hey, I need who's around me that's ALS. They can tell you, and they can say, hey, we're going to make a beeline for the hospital, but just tell ALS to meet us at this location. So we're still moving towards the hospital, but we can do a quick stretcher swap and say, yeah, that's an ALS intercept.
What, so you just transfer the patient onto their rig and they
Yeah,
take over?
so you would take the patient should be on the stretcher in your truck, right? Take the stretcher out. They take their stretcher out. You give them your stretcher and you take their stretcher. Guys, again, this is a fairly new universal activation in hospitals now. Okay, used to it was just a stroke alert, a trauma alert, and a STEMI alert, which means a heart attack. Now, this is a very time-sensitive patient. If they are in septic shock, there is now a universal sepsis alert. So again, make sure you're recognizing that your patient is septic, they're in septic shock. You're going to tell Grady, hey, activate the sepsis team. Guys, what's going to be a really strong indicator that your patient is septic?
Big fever.
Fever. Okay, that's part of your body's design. Is your body temperature is elevated when you're fighting off infection. So 9 out of 10 times, if your patient's septic, they're going to have some type of fever. It's a big one.
What did you say those 4 emergency department special needs were?
Trauma, stroke, STEMI, STEMI, which means an active heart attack, STEMI, and sepsis. Guys, neurogenic shock, what are you going to do?
More or less the same thing as the other ones.
Okay, so shock management, but what else? What's different from this patient than the others?
Well, we have a severe neck trauma or something, right?
Okay, so what do we need to do for this patient?
Backboard.
Backboard. You're still going to provide shock management, right? But this patient needs to be backboarded. What's your treatment for anaphylaxis? Epi, what's your dose?
0.3.
Like 3 milligrams.
0.3 milligrams. What's your concentration for adults?
1,000.
1 to 1,000. What's your dose for peds?
10 bed.
Ooh, God no.
Concentration.
All right, 0.15 milligrams. Technically, the concentration is 1 to 2,000, but it's pretty much the same. Psychogenic shock. Yeah, guys, if they pass out, make sure they didn't hit their head. They didn't obtain an injury from passing out. Do a thorough check with vital signs. Try to provide any type of like moral support, or if it was the sight of blood that triggered this, remove them from that environment if possible. Okay. Y'all can't do much for hypovolemic shock, right? Shock management, high flow O2, lay them flat, conserve their body heat, and haul butt, right? We're going to talk about this in the next chapter. Everybody good? Okay. That is shock.